We're going to shift gears a little bit from to moving toward more formal institutions and stigma, and it's a real great pleasure for me to share our work with you in bringing quality improvement to reducing stigma in healthcare settings. And I'm going to tell you about our work in the region. So I think, as we know, and we have already heard, stigma and discrimination still have terrible consequences. The very people who are meant to be protecting, supporting, and healing people living with HIV often discriminate against them. The people who should be in their care deny them access to critical HIV services, and then we wind up resulting in more HIV infections and more deaths. And we know that our goals in terms of reaching epidemic control are to reach, by the end of 2030, 95, 95, 95. And we need to make sure that no one is left behind. And here, in this region in particular, one of the goals is zero discrimination. And as is quoted here, nothing other than zero discrimination is acceptable. Equity is one of the principal domains of quality improvement, and was originally described in this document, Crossing the Quality Chasm. And equity is providing care that does not vary in quality because of any personal characteristics, such as gender, ethnicity, geographic location, socioeconomic status, and of course, medical condition. And in the recently published Lancet Commission on High Quality Health Systems, which is a wonderful document, they make a very clear statement. The quality of care is worst for vulnerable groups, including the poor, the less educated, adolescents, those with stigmatized conditions, and those at the edges of the health systems. And so the theoretical framework for our work in the health systems is based on this logic model, and we've borrowed, one of my colleagues, Laura Nyblade, put this together, which is that we know that there are different manifestations of stigma, experienced stigma, and anticipated and perceived stigma, that lead to avoidance, harassment, and refusal to treat. But they're driven by things that are actionable: fear of transmission, awareness of stigma, attitudes, and the institutional environment. But when they are present and they result in stigma and increased stigma, then we are not going to see those results in the treatment cascade that we want to achieve, including the outcome of viral suppression. And indeed, there has been a call for a fourth 90. And this is from a recent publication where it is stated that although WHO calls for person-centered chronic care for people living with HIV, it fails to account for the needs of virally suppressed and other people with HIV who must contend with other intense challenges, including apprehension about discrimination. So they propose adding a fourth 90 to the testing and treatment target, which is to ensure that 90% of people with viral load suppression have good health-related quality of life, which you see in this graphic, and this is from this article by Lazarus in BMC Medicine. And so I think it's important for us, as we focus on outcomes, it's not just viral load suppression, but it's about experience and quality of life. So this led to our initiative, which has the following aims, which is to apply quality improvement methods through a multi-country learning network in Cambodia, Laos, PDR, Thailand, and Vietnam, with the goals to support ministries of health to implement QI learning networks in their countries, focusing on stigma reduction in health facilities by testing changes, instituting routine measurement, and fostering peer learning. To implement policy initiatives that will encourage stigma reduction activities in healthcare facilities, to empower patient groups to take on an active role in quality of care decision-making at all levels of the health system, facility, regional, and national, and to exchange knowledge that advances learning about how stigma can be reduced in healthcare facilities to improve the lives of people living with HIV. And so our funding was such that the initiative was set up that our work is at the multi-country level, and the network And we support the ministries who then support the facilities. And so the activities at the facility level assess stigma and discrimination routinely among healthcare workers and people with HIV, implement the quality improvement activities to identify barriers and identify interventions to address them, and then test and adapt those interventions. And those then go back up to the national level where they can be shared and aggregated and then shared again at the multi-country level so countries can learn from each other. And so typically when we think about quality improvement, we think about clinical data. And clinical data then informs quality improvement and results in better outcomes. So this initiative is a little different in that we're using healthcare provider surveys to generate data that can result in quality improvement and patient feedback. And so it's those three different streams of data that can help identify the areas and the priorities for quality improvement work. So I wanted to pause for a minute because I don't know how many of you are familiar with quality improvement, and so I'm going to give you a lightning round version of quality improvement. So distilling quality improvement into principles, we like to say that every system is perfectly designed to achieve exactly the results that it achieves. And so if in the clinic that you work in or you go to as a patient, that clinic is producing discrimination or making people feel stigmatized, that system is essentially designed to do that. And it's not going to change unless the system changes. And so to do that, then we focus on how we understand our work in terms of processes and systems. The teams of providers and patients help identify solutions that can address the gaps. Ideally, we want to focus on patient needs to drive change. Test and measure effects of change. And this is a particular principle of quality improvement, that we implement small-scale changes to see what might work in real time, and then if they work, we scale them up. But if they don't work, we don't waste our time continuing them. And then we rely on peer learning, so that if one clinic is doing something, they can share that with another clinic and move things along faster. Also, some of you may be familiar with quality assurance, and that's different than quality improvement. Quality assurance is trying to get rid of or prune the bad apples out of the barrel. And so we get rid of those things all the way at the end of the curve that are a problem. And it's not that we shouldn't do that, but it's a very specific thing because we have to go to find the problems and get rid of them. Quality improvement looks at the entire system of performance, and the idea is that we want to narrow that gap of variation in performance in the system. So we want to reduce the variation. We also want to move that performance along the axis to improve our rates at the same time. And so essentially what we are doing is both narrowing variation and improving our results through the quality improvement process. And so if you keep those images in mind, I think it gives you a sense of what we're trying to do. So in this initiative, we used a validated assessment tool developed by Laura Nyblade that had been validated in several countries and had already been used in both Thailand, Laos, PDR, and in Ho Chi Minh City. And the members of the network went through a modified prioritization process to identify 8 measures from this 51-item survey that could be used in real time on a frequent basis to drive quality improvement activities. The goal was to have the survey administered to all healthcare workers in the facility and not just workers in the AIDS program, since obviously people who get care in a facility also have to go to the lab, they have to go to X-ray, they have to register at the desk, and they can experience stigma and discrimination any place in the institution. And so here are the domains of measures, and they include infection control, fear of transmission and avoidance behaviors by staff, attitudes about people with HIV in key populations that affect their willingness to treat them, manifestations of enacted stigma, which can be observed, healthcare facility policies, and then this survey has a special module focusing on pregnant women living with HIV. And the 8 measures that the group selected were about whether somebody had observed stigma in the institution, whether they were wearing double gloves when providing routine care, their attitudes about whether women with HIV should be allowed to have babies if they wish, and how worried are they about getting HIV from blood drawing. Similarly, whether or not they've observed instances of poor care being provided to people with HIV, if they think they have adequate supplies in the facility, if they avoid contact with people with HIV when they provide care, and whether there are guidelines and policies to protect patients living with HIV from discrimination. And the countries could modify those questions if they want to. So the baseline network results of the surveys show that we have some problems to deal with. And you can see that 12% of providers avoid physical contact when caring for people with HIV. A third wear double gloves routinely. 22% have observed colleagues not willing to care for people with HIV. And almost half, or a little more than half, think that pregnant women with HIV should not have babies. That's just a sample of the results. I won't go through this in detail. And we do have follow-up results from the network, but they haven't been tabulated yet. Now, across the 4 countries and the facilities, a number of different interventions have been tested. And again, I'm not going to read through all of these. They are available online, and I'll show you where you can get them. But they can be grouped into different system-level issues. The actual way in which care is delivered in the facility, and that might involve things like flow. And I'll show you a couple of examples from countries. How there is communication and knowledge about stigma and transmission of HIV. Setting up measurement systems to actually find out what's happening and if there is stigma and discrimination in the hospital. Involving people directly in care and hearing from people directly about their experiences, and then organizational activities to engage the entire group of staff and facility in activities and policies related to stigma and discrimination. So here's an example from Thailand, and you can see highlighted in red where some of the problems are. Again, some of the things I talked about, but they also ask about whether status is disclosed without permission, which was a problem. And this is from Champasala Hospital, where they've implemented a number of different interventions, and they got rid of a queuing system that put people with HIV in the back, so they had to wait longer for services, and particularly in the dental clinic and in the operating room. They stopped the zoning system in the patient wards by HIV status, unless, of course, there was a respiratory transmission and airborne transmission problem. Stopped separating equipment by HIV status, and they began to look more closely to prevent issues of inadvertent disclosure. Here's an example from Vietnam, and what I'm showing you here is a fishbone diagram, which is a root cause analysis to identify causes of stigma and discrimination that is generated by the staff directly. There were some results here. This is the pre-intervention and post-intervention from a region in Vietnam, and you can see that there's some trends in a positive direction in the second round. In Laos PDR, this is an example from Champasala Hospital, where there were dramatic results from baseline to the second round. And I'm going to tell you the story about this hospital in particular. This is a hospital that decided that this was something they had to address not just in the HIV clinic, but through the entire hospital. And so they set up a separate process for greeting patients when they register. They would have somebody to orient them to the way the visit was and ask them about their needs before they actually went into the visit. They had staff meetings to reinforce policies about stigma and discrimination, and weekly case study conferences that people could talk about examples. And then there were specific trainings about transmission in particular. Another area in our work is to focus on patient experience, and ministries of health are choosing their own methods for getting routine patient feedback. examples of different methodologies have included surveys, exit interviews, patient forums, storytelling, comment boxes, and consumer advisory boards. And then a network subgroup was put together to come up with common questions across the network for asking about experience. And they're here. Was information explained clearly? Was the clinic welcoming? You can read these here. I'm looking for the timer, so okay, great. Thanks. And so in Laos, many years in working in the field of quality improvement, I walk into hospitals with comment boxes. And in almost every hospital, they're not opened. They never look at them, right? So I literally almost fell off my chair in this particular hospital where we found, and there are others in the south of Laos in particular, where they open them every week. And they actually analyze them and address all of the comments. If there's an individual concern about a provider, the head of the clinic talks to the provider, and then the issues are addressed in their quality improvement work, and they have talks in the waiting room to actually address these issues with the clinic and get the people who are coming to clinic and then hear what their concerns are. And it just so happened that this dovetailed with their national quality approach, which is called 5 Goods and 1 Satisfaction, where each hospital was focusing on the 1 satisfaction. And the ministry was really happy that stigma discrimination and this initiative was a way to feed into that and align with that national initiative. And so that's why those results looked so good on the second round, was that all of these activities were occurring at the system level. Some of the other options that we've seen, this is from Cambodia and through the Linkages Project, and with the ministry, they're collecting data from patients in a survey on a tablet when they come into the clinic. This is from Thailand, where there's also been a survey, and it's been, this is Cambodia also, where they're also asking about experiences in the sexual and reproductive health clinic in addition to the HIV clinic. And in Vietnam, they are starting consumer advisory groups in the clinic. And so in Binh Duong, there is a new consumer advisory group where they get feedback routinely, and the consumer advisory group looks at the data and then helps plan the interventions. One of the big challenges is, people will say, well, what difference does this make? If you're only focused on epidemic control, people want to see the hard numbers of viral load suppression, and particularly our current funders. And so we didn't really have funding to try to correlate clinical data with specific experiences of stigma and discrimination, which also involves a much more formal research study and protocols. But so we did decide to ask questions about health literacy and whether patients knew their viral load results and whether or not they knew when they were due for their viral load test. And so that is now something that we're piloting, and those questions are on the right-hand side there. But there are a number of challenges, as I said, linking the data together, having a formal methodology to do it. Even if we do it, we still aren't getting information from the people that don't come back to clinic or who never come at all. And that obviously is where there may be the biggest effects of stigma and discrimination. The aggregated performance scores may mask results among key populations, and particularly in the countries that we're working in, almost none of the clinics collect data on key populations routinely to disaggregate the data. And that's something that I think is a huge priority that we all have to address as we move forward. And so then it raises the question, is health literacy an adequate proxy? In our program, we have these multi-country networks. Here are pictures from each of the network meetings, and then people are also able to join remotely through Zoom. We share best practices through spotlights, and they're on the web, so you'll be able to look at them. But there are a number of challenges that we have to address to make something like this work. I want to go through them quickly. I'll probably run over just a minute or two. But I think it's important to think about as we move forward with stigma and discrimination reduction programming and thinking about quality of healthcare services. So first, the S&D activities are often in one part of the ministry, and the quality services, quality of care program is in another part of the ministry. And they often don't talk to each other, or they don't coordinate, and that's been a challenge. And in some countries, they've been able to overcome it, and some they have not. Getting people to accept using a different source of data for quality improvement, namely the surveys or patient experience, was another challenge to overcome. Fortunately, it was one that has not been an ongoing problem. The lack of integration of the disease-specific, in this case the HIV program, with the general quality initiatives has also been a problem, because there are separate systems for measuring HIV care and performance from the rest of the quality unit. And if we want to really look at the quality of care that people with HIV experience outside of the HIV clinic, it's not under the purview of the HIV program. And so there has to be a way to bring those pieces together within the quality initiatives as well. The methodological challenges of getting patient experience data routinely is often an issue for healthcare providers, because they need to figure out how they're going to routinely ask questions of patients in the clinic and then take qualitative data and synthesize it to find what the key themes are. So it takes an extra activity and something people have to think about to routinize as they go forward to act upon patient experience information. I've already mentioned the issue with disaggregating by key population, and also the issue of not getting information directly from people who don't come to clinic. And I think that's a call to action for us to coordinate the community-based initiatives focusing on stigma with the healthcare facility-focused initiatives to figure out where we can combine data to then have actionable data on the healthcare side. But there have been some successes. I think we've seen that cross-country learning has been very successful in the network. The ministry teams have been really engaged and have also been working with implementing partners and civil society organizations to move the work forward. You'll be hearing about this from Dr. Thuy in terms of the Vietnam experience in just a moment. That the facilities are moving forward with integrating data from patients and healthcare workers into their QI work. There's a heightened capacity at the national and site level to monitor stigma and discrimination and apply QI work, and a gradual adoption and understanding of how to use other data sources for quality improvement. And most importantly, I think there is a developing consensus that HIV-related stigma and discrimination in healthcare facilities is actionable. For many years in my work in the US, people would identify stigma as a barrier and then throw up their hands and say, we can't do anything about it. But I think we've seen many examples here that tell us that we can and that we need to act upon it urgently. So as I mentioned, the information is now available. Our paper about the network was just published on Monday, and so it's open access, it's online, and if you can contact me if you're not able to access it directly. And I would like to acknowledge PEPFAR for supporting the initiative and the many people who have been involved with me in developing and implementing the network, because it's really been this massive group effort. So thank you very much.